until Hassager showed that by ablating in one part of the pulmonary vein he could stop. Important to know because I think it teaches us a lot. This is called, the title involves this acronym atrial fib begets atrial fibrillation. And what they have is these goats which they instrumented so that they can, using a computer, they would stimulate at a very fast rate. Burst stimulation at a very fast rate, and then they see what happens. So when you start it out at the very beginning, and you can see the burst stimulation on the left side here, and then the atrial fibrillation, you can make the atrium go into atrial fibrillation rate for days on end, okay? And now you give the burst stimulation. So you're pacing them fast, and then you pace them faster again at a burst. Now, the atrial fibrillation can last for up to a minute, and then if you do this for even longer, for weeks, now the atrial fibrillation becomes sustained. So what does this mean? It means that atrial fibrillation, a lot of times, it correlates with what we know, that atrial fibrillation coexists or happens when there is other kinds of supraventricular tachycardia happening. That also, the longer you've had atrial fibrillation, the harder it is to try to do rhythm control. And also what we all know is that atrial fibrillation, whether you cardiovert, whatever you do for atrial fibrillation, it's here to stay. Once you've seen atrial fibrillation, you know it's going to come back with time. Lone atrial fibrillation or primary atrial fibrillation, there's something happening in the atrium, right? If you look at the histological samples of these, on the left-hand side you see normal tissue, the myocytes are intact. You look on the right-hand side, you see the myocytes are in disarray. There's vacuolation, there's fibrous tissue and fatty tissue interspersed between the muscle cells. This all can facilitate the development of re-entry as we talked about. In other words, atrial fibrillation is about time. It does not happen overnight. And this is true as we look at epidemiological studies. If you look at the cardiovascular health study, by the time you're looking at people who are older than 80 years of age, now you can see that there is approximately 10% prevalence of atrial fibrillation in this kind of a cohort. If you look at the general, it depends on your detection method. If you were in the Framingham study, they were taking an EKG every time you came to the clinic, once every 3 months or whatever. But now the more you look, the closer you can look for a longer period of time, now you have higher detection rate. And therefore the numbers change with time. And so we know that there's more atrial fib than we thought. What is it that we worry about regardless of symptoms? The main thing that we're worried about is what you heard the last speaker speaking about, Dr. Mekki. Which of these two patients did you know had atrial fibrillation before? And the truth is, just like there is AFib that we don't know about, there's also strokes that we don't know about. And I will come to that. But let's first talk about how do you look for the atrial fibrillation? I was beginning to talk about that. This is from the Crystal AF study. After Medtronic made this device that you can put under the skin, and now it's watching you 24 hours a day, every day. And what these people did, what this study did, is somebody presented with stroke and you cannot find a cause. So this is called a cryptogenic stroke, a stroke that has no underlying, easily explainable reason. So no AFib, no atherosclerotic plaque, the carotids are normal, there's no valvular lesion. What's going on? So they put this loop recorder. And sure enough, very soon after randomization, within 6 months, you're going to start to see that people, that you can see people who are very evident that there is atrial fibrillation. By the way, how much atrial fibrillation? What do we talk about? Patients who had AFib prior to getting the device, and we follow them for a while and see how many of those who had AFib early after the implant were likely to develop clinical atrial fibrillation. So the first 3 months, from the baseline to follow-up 1, is a watching period. How many of these are going to have any kind of atrial fibrillation? And then later on, we'll see how many of those develop atrial fibrillation that we used to think of as clinically significant. We used to think that a thrombus will not happen before 24 to 48 hours. That was the clinical, what we called clinical AFib. In other words, the prevalent idea was for the clot to happen, the atrium is in standstill, and now the clot was happening. So we look for 48 hours. So sure enough, people who have any kind of atrial fibrillation of any duration, any high rate of atrial activity, 3 months on for up to a year, were much more likely to develop atrial fibrillation that lasted for 48 hours or more. So we have silent atrial fibrillation. Atrial fibrillation that you know that the patient comes and complains about palpitations or fatigue or this and that. That is only part of it. The rest of it is much more invisible to you, but maybe as equally significant. And just like we have silent atrial fibrillation, we have silent strokes. When the largest study then to look at people saying, what is the implication of having these short episodes of atrial fibrillation is the ASSERT trial. And again, they used 6 minutes, which was not, they followed the crystal AFib, so they used the same definition. And the same thing happened. If you had atrial fibrillation, you were going to continue to have more of that. So this is the breakdown of those who had the ASSERT trial. But I want to show you this because these are the people who developed strokes. 50 patients developed strokes. Half of them had AFib and half of them did not. You look at the time of the AFib relevant to when they had the stroke. The stroke is the middle line there. It's 0 time. Notice that at least patient number 24 had the red line, the red dots are when the AFib happened. Patients number 12. AFib because 6 minutes are enough. Not when you had AFib, because now out of the 26 patients who had documented AFib, 8 of them were outside of the 1 year before the episode window. 1 of them was after the stroke. The AFib was detected after the stroke. 7 of them were detected more than a year before the stroke. So AFib itself is no longer relevant, almost. We're almost at a point where do we even need AFib? We're talking about the CHA2DS2-VASc score and what the comorbidities are dictating your risk of stroke much more than the duration, the type, or the length of the atrial fibrillation. In fact, this is exactly what's shown in this study, which is called SOS AFib. They monitored 10,000 EGM reports, and this is from greater than 10,000 patients followed with dual chamber pacemakers or ICDs, and this is from Europe. And they look at the different risk factors for them having stroke. And when you look at the right-hand side of the slide, right, and this is all descriptors of the AFib. Was the AFib greater than 5 minutes to versus less than 5 minutes? Is the AFib greater than 2 hours, greater than 1 hour, 24 hours? All of them are very equivalent in terms of conferring risk. And that just drives home the point that it has nothing to do with the duration of the atrial fib. Therefore, this is my last slide actually. The European guidelines now tell you what you should do when you see somebody with a pacemaker who has registered a high rate. You'd like to see proof that this was really AFib and not artifact or something of that nature. So either an EGM or an EKG, but very early on the decision has to come, can you anticoagulate this patient or should you be anticoagulating this patient based on the CHA2DS2-VASc score, not based on the AFib itself, okay? And I want to tell you that in answer to this question, what kind of AFib are we dealing with? Let's start thinking of atrial fibrillation not as a disease, not one disease, not two diseases, but not a disease at all. Rather, let's think of it as a marker of high risk for stroke. AFib did not happen overnight, it happened over time. It happens to elderly people who have a lot of comorbidities. And when it happens, and we're talking about non-valvular AFib, when it happens, usually the CHA2DS2-VASc score is high at that time, the risk of stroke is high, You've seen one, okay, there is an analogy we have in the States. If you see one mouse, there are 200 mice in your home, okay? If you see one mouse, if you've seen any AFib or any evidence of AFib, the decision has to be made very shortly as to whether to amplify it or not. I apologize for going over time, and I thank you again.